Hello, this is a hopefully short slideshow that is just about starting an IV. It's kind of the cognitive information associated with starting an IV for paramedics on this, I should say maybe during this accelerated course. We don't have a lot of time to talk about starting the IVs before we actually have you practicing IVs. So here's that. This in the old school courses where we had a whole bunch of time, we would usually cover this at that same time that we're covering fluids and electrolytes. So we're going to just talk a little bit about starting IVs and then get into maybe some of the complications, information you'll start seeing on quizzes right away. So here's that IV fluid composition. Obvious stuff here. They all have to be sterile. And when you're opening up your IVs, really pay attention to the packaging. When you see that's really moist on the inside of that kind of the tougher external packaging, there's a possibility that there's a problem. And then when we're looking at the IV fluid, we really have to pay attention to, does it look like this is all intact? It should be dry, and there shouldn't be any what we call sinkies or floaties on the inside of the IV bag. IV bags can end up stuck in a truck somewhere and baking in the sun, or get too cold and freeze. And both of those things can cause there to be a problem with the, what would you say, with the idea that they're completely free of any viruses or bacteria, fungi, all of that kind of stuff. So the IV solutions first, we're going to talk about crystalloids and colloids here. And we pretty much just carry crystalloids. So that's the normal saline, the lactated ringers, and the D5W. So there's dissolved crystals in these solutions that you can't see. Basically salts or sugars. The particles are fairly small and they're able to get into the tissue really well. Most of the time when we're talking about the crystalloid solutions, they're isotonic too, but they could be, and even in the pre-hospital arena, we could see hypertonic solutions. So these solutions, one of the reasons we use them is they have a longer shelf life, and they can cross the membrane pretty quickly. So they do alter your fluid levels, and they can get in there and start bathing the cells. This 3-to-1 replacement rule is a little bit old school stuff, but there's two good answers to how much fluid we give to people. I would say most of the time when we start an IV, we give fluids just to keep open the IV. That is a kind of a moving target for what that number is, but generally you could say 25 milliliters an hour, and in some hospital systems or areas it might be 20 milliliters an hour or 30 milliliters an hour. And we start saline locks and give a little bit of fluid, and our hope is that we just have an IV open in case we need one. But then sometimes we replace fluid, or we're trying to improve the patient's condition by giving them fluid. One, and it might be an old school, but it's still kind of in our curriculum, is a 3-to-1 replacement rule. And this is the idea that when we give a liter of fluid, or how much ever fluid, 2/3 of the fluid will leave the vascular membrane and go in and bathe the cell and go into the cell. So if we wanted to improve how much blood, or I should say how much fluid is in the vessel, we give 3 times the amount that we would want. So let's say a person lost a liter of blood, we would give them 3 liters of fluid, estimating that 2 of those liters would be out of the vasculature within 60 minutes. 3-to-1 replacement rule. Our fluids don't carry oxygen, so they also cool the patient. So usually we're giving IVs that are at room temperature, so they're going to cool the patient, which isn't great for a trauma patient. And they're not going to help with pH. We start looking at the IV fluids, you'll see that the pHs well below 7.0, which is in the acidic area. So we shouldn't think of IVs as giving acid because it isn't quite like that, but we should realize that it's not going to fix acidosis at all. So here we're at this 20 milliliters per kilogram. That is kind of the normal IV fluid replacement. So instead of that 3-to-1 replacement rule, we usually think of it as 20 milliliters per kilogram. And then another one, if they're continuing to lose blood, so they have a non-compressible wound or internal bleeding or bleeding that is not controlled, however you want to say that, then we want to limit how much fluid we're giving, and that is enough to maintain perfusion is a right answer. Other ways that we say that is a blood pressure of 90, a radial pulse, and good mentation in the absence of a head injury. So that is all adult stuff. When we're giving fluid boluses to pediatrics, makes it a little bit simple again, and it's just 20 milliliters per kilogram. And so the other type of IV solution is a colloid. The military has used colloids. I think they use hextran. These colloids have a bigger molecule, and that molecule is usually something like a protein or a big sugar molecule. So you'll start to see things like starch or dextra or albumin somewhere in the name. So here across the top there, we'll see that albumin, dextran, hespan, and there's a few different ones that are basically gelatins. And gelatin, you can kind of think of that with sugar, right? Big sugar molecule. The molecules will stay in the vessel. And so what happens because of osmosis, they will pull water into the blood vessel. So this was a big thing, kind of a Vietnam era thing for a while. They would give something like albumin, and that would pull water into the blood vessel and improve the person's blood pressure. So instead of having to give them a liter of water, we could give them, let's say, 250 milliliters, easier to carry and such. And then they would bring in a bunch of water from the tissue into the blood vessel and improve the patient's blood pressure. The problem with that is we're robbing the tissue. All right, so we go back down to like, what is shock? Shock is poor or inadequate tissue perfusion. And when we're giving these colloid fluids, we're bringing water out of the tissue. So you can't really make a good argument that it's great for tissue, which is the problem, inadequate tissue perfusion. When we do give colloids, you would expect that to be a short-term thing, and it would be followed up by giving them a bunch of fluid so we can replace that fluid that we robbed them of that's left the tissue now. Fluids are also characterized by tonicity. So this first one is isotonic, and that's what we usually give. It's basically the same concentration as what we have in our cells, which should be about the same that is in our interstitial, which should be about the same that's in our blood. So that is an isotonic. And here you might have seen these pictures in your book. I added a few little dots there to kind of signify that we have an equal amount there of particles on both sides. What's extracellular and intracellular here. And again, we could change that and make it intravascular or extravascular too. A hypertonic solution would be, would have a lot more particles there. And water then is going to be what moves the quickest. So when we give a hypertonic solution, we are going to pull water into the bloodstream, right? So water will follow from an area of low concentration to greater concentration. So when we give a fluid that's hypertonic, it pulls water out of the interstitial and into the vascular. That's often how we might have to address it in a test. All right. So if you think about that, that might be something we would give to. Wait, I'm gonna let you think about that for a second, but we might give that to a what? What do you think? who would we want to give a hypertonic solution to that would draw fluid out of tissue? And the one that I think of first is probably a head injury. If we wanted to drop somebody's intracerebral pressure, we might give a hypertonic solution. And then a hypotonic solution is going to have a lower amount of concentration. So the water is going to flow the opposite way. So we're just talking about that extracellular going intracellular. But again, when I think of hypotonic solution in the paramedic way, I like to think of this as where will the fluid go when we're talking about the vessels. And if it's hypotonic in a vessel, water will flow from an area of low concentration to greater concentration. So the water would flow out of the vessel and go into the tissue. So when we give medications, we often give medications with D5W. And D5W seems kind of weird because it put sugar in it. Seems like it would be hypertonic, but it's hypotonic. D5W is hypotonic. And we give medications in a hypotonic solution, D5W. One of the reasons for that is when they do the studies on the drugs and they're trying to figure out, how quickly the medication is metabolized and such, they want to take out one of the variables, which is how much fluid we're putting into the blood vessel. When you give D5W, the fluid flows out of the blood vessel into the tissue pretty quickly, so it manages the variable of increasing how much fluid is in the vessel. And then the isotonic solutions that we have are things like lactated ringers and D5W. All right. So again, D5W is 5% dextrose and water. It's considered isotonic in the bag and hypotonic once it's in the body. It's just the way the body works. Hypotonic solutions are going to hydrate the cells, right? So they hydrate the cells, leave the vessel, and go into the cells. We call that third spacing. So when we're doing that, we should expect some swelling also. And hypertonic is going to pull from the intracellular. It's going to help bring up the blood pressure a little bit quicker than the other ones, because not only is the vessel is going to have our fluid, it's also going to have the fluid from within the body that's going to get pulled into the blood vessel. So here's the techniques for administration. All right, so first of all, first and foremost, we have to keep everything sterile. All right, everything has to be clean. That's what we have to kind of get used to. The idea that when we're setting stuff up, that we need to kind of think about that in a way where when we're in the dirt or on a, next to a patient's couch or on the bench seat of the ambulance, we're able to control our equipment and keep that in a way that's everything is going to stay sterile, and we're going to use an aseptic technique. We're going to gather all of our equipment, and this is one of those things that I want you to get good enough at, where this is one of those cognitive unloading things where you're just very, very used to just pulling what you need to pull, putting it maybe in the right place all at the same time. I'm not going to tell you where that is. You figure that out where you want the stuff. And then every time that you're starting an IV, you're going to be able to get that muscle memory thing going, and you'll be able to do it in nice bright conditions. And then maybe when there's a low light condition and stuff is kind of dynamic around you. So the one thing that I want to make sure that we're building up here is our habit of getting a sharps container close by, opened up, and we should make it so when we get done with the IV stick that we're going to pull the IV needle and be able to drop it directly into a sharps container without anybody else's help. A lot of times when somebody has to help us, that's when we end up poking somebody because they're now holding onto the sharps container while we try and drop it in there. So we're going to choose an IV fluid. That's going to be pretty easy. We're just going to be following protocol. Almost always normal saline. Ringer's lactate works great for some shocks and burns, and I like it for the environmental stuff like heat exhaustion. Once we pierce a bag, we have to use that within 24 hours. And IV bags come in different fluid volumes. Let's take a look at some of the stuff that we'll be looking at. Here, we're going to look at an expiration date, make sure that we have sodium chloride. We would want to look for floaties and sinkies on the inside there. Make sure it's not wet. That's a medication port. That's how we would push medications into an IV bag. And then the other one is where we see that blue tab, but we pull that off and we're able to spike our IV fluid there. And then here, of course, we have different size IVs, and those are kind of the obviousness of one is when we're going to give a bunch of fluid, one is basically a medical patient, and a 250 bag is usually for medications. So we're going to use administration sets, and that's usually we're going to use a macro drip. You usually just get used to what your system has. For our system in West Michigan, we usually have 10 drop type of sets by Baxter, and then every once in a while you see ones that are 15s. I think nowadays, lately, it's been about 50-50, about in 10s and 15s, and every once in a while you might catch that there's a 20 dripper. And basically what that number means is it would take 10 drops to make 1 milliliter of fluid. There's also 60 drop sets, and those are almost always used for medication drips. Makes your math easy. And here's a blood tubing here. When you have, sometimes I just call that a Y tubing. And then on this one here, you can see there's a little bit of a pipe there, and that is a mini drip. Choosing your IV site, put a tourniquet on there, a venous tourniquet or a constricting band, and look for a good IV. We like to go distal first. Look on maybe the back of the hand. My favorite is the wrist, which is also called the interns vein. Look up the forearm a little bit, and then up in the antecubital on the inside of the elbow. Nurse, when we start an IV, one of the rules in the hospital is they're not supposed to draw blood basically south of that IV. So they don't like it. You're not supposed to start IVs after you poke one way up in the antecubital. You're not supposed to poke south of there because your IV fluid will be going right where they were trying to stop bleeding from the first poke. So they'll end up with a big bruise. So try and go as far down or distal the arm or into the hand as you can. Find your vein. I'm not going to tell you that via PowerPoint. That's all just practice, 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 and work your way up as you're missing, basically. You're going to hopefully at the very beginning just look for those big veins and then go for them. I don't mind just starting antecubital veins if that's where your what would you say your confidence is at. And this part right here, there's just all kinds of different ways of securing the vein here. All right, so you choose what you want to. In the picture here, we have somebody who's pulling down, and they made a fist out of the hand, and they're pulling the skin taut. You can do that like this. You can do it from the edges, so you're maybe medial and lateral to it. And I like to actually go, north or proximal and pull up a little bit, and I think that holds the vein stable. It kind of depends on the patient. And consider the patient's opinion. Sometimes they like it. If the person is going to be eating with their right arm, you might want to avoid putting something in the antecubital because very often that catheter will shut off when their arm is bent, and it might cause them some uncomfortable. It might be uncomfortable for you to put it there just the way the tape is and everything. Avoid trauma and injury and an infection. Try and make it so the patient will be able to live with that IV for a little while. The rule in the hospital is usually they take out our IVs within 24 hours. Most hospitals have a rule that our IVs are dirty, so they will replace them anyways. So don't feel like it's such a big deal if you have to go antecubital. That's fine. We can also go down to a leg vein. I like those for pediatrics. And we don't usually do scalp veins, and I don't like any of the other ones. I truly don't like forearm ones that much. They hurt the most, so I like going the back of the hand, the wrist, and then go up to the antecubital. The IV, we don't really have to choose that much. We just have a bunch of over the needle. All right. This is like quiz question kind of stuff. We have over the needle catheters. Means the catheter is over the top of the needle. Butterflies, you might have that, and that's just a stainless steel needle, and that whole thing is going to stay inside the patient. That's kind of a pediatric thing. And then we have through the needle, but we don't generally have them pre-hospital. Those are usually for central lines, and they're big needles. So if you can think about that, that's usually a big needle going in. Very often they do this with the help of ultrasound now, or they do immediate x-rays afterwards. And this is how they do some of those central lines where it's a big needle. They pull out a trochanter basically, and they feed a wire into the patient. And then the flexible catheter goes down the wire into the patient. Complicated. Paramedics don't do that anymore. So we're going to use a constricting band to find where we want to go. What I would suggest is if you took some, you immediately went to finding it. Once you find it, undo your constricting band for a little while. That will pressurize the system, and the longer you have it, the more pressure there may build up. So by the time you hit them with a needle, it's going to cause there to be a lot of bleeding underneath the skin. So if you take a long time, undo the constricting band and then tie it up again. Practice this a bunch of times, because when you start doing this on patients, you don't want it to look like you're just brand spanking new at tying the special little knot that we have that's very easy to undo when you're done with the poke. And remember, this pressurizes the system. So once you have the needle in, one of the first steps is to undo the tourniquet. And that will depressurize the system, and it'll make it so you don't have so much blood on your patient when you're trying to take the needle out, put that into the sharps container, and then take the IV line and put it into that hub. Keep the bevel side up. That's just a matter of pain. The sharpest needles will hurt the least amount, and when you use those correctly, they hurt the least even more. So maintain your traction. You're going to insert that IV catheter in and wait, and you want to be able to visualize the chamber to make sure that you know exactly when that needle has entered into the vein. So you're going to prep the site, keep your traction however you would like to do that. Insert the needle, I would say 35 degrees. A lot of places you'll see 45 degrees. That's a pretty steep angle. Push through the skin. Here, I would say the quicker the better. Quicker is going to be less pain. Bevel side up, go through the skin, and then hopefully right into the vein. Once you're into the vein, and you see that by watching your drip chamber, once you're there, you want to drop your angle down to about 15 degrees and keep moving the catheter up a few millimeters. So I think in your book it might say a few centimeters. That is super difficult to do. So I would say maybe 4 or 5 millimeters will be good. And then you start to slide the sheath off the needle into the vein. Once you're there and your hub now is up next to the skin, you'll want to put your finger where you think the end of the Teflon catheter is to occlude the vein. All right, so you're not going to be able to see it. It's inside the vein. You'll put a little bit of pressure there, and now you're getting ready to remove the needle. And again, this is the careful part. This is where we would need you not to cause there to be a poor or a non-aseptic technique. All right, so you can't put your little sandwich camp right into the hub because that is not sterile. So here we want to make it so we have a gauze underneath the hub that's going to collect a little bit of blood. You probably have a little bit of blood on there. You already have your gauze underneath the hub, so that's okay. And then as you remove that needle, it'll go in one nice smooth motion into a sharps container. And then you're going to grab your IV catheter and put that right into the hub. Now you're going to tape it down, start running your fluid. You just want to run a little while, like 10 seconds of fluid to make sure that you don't have a bunch of edema there, that you don't have blood coming back up into the tubing. And then you'll tape this down, and that's the chevron method that we like to use. This is what the Army and Navy calls the ruggedized IV. That's the best way to start an IV and to tape it down. It's also probably the most difficult. I like to teach this because then as you go on with life, you know how to do it best. And if you don't want to do it the best way, you don't have to do it the best way. Later on, you can just throw a opsite over the whole thing and call it good. I like teaching this truly because it's the hardest one. If I don't teach you, you'll never learn. Just one way to think about it. So good taping is important. Anyone who's been around for a while, if you guys have a pretty busy system in Lansing, people will get lazy with their tape downs, and then they'll get a bunch of IVs pulled out, and they'll go back to maybe the way they learned it in school. I learned it in the Navy as a ruggedized EMT. They didn't use that term back then, a ruggedized IV. But then when I went to Davenport, learning from nurses, they all taught me with the chevron method. So I think it's an important way to kind of get a good foundation, and then you can change if you want to. I'm not your dad. Cover the site with a sterile gauze. You just poked them. They now have a hole. You own that hole there. You don't want that to become infectious, so do whatever you can to make sure that that doesn't cause the patient infection. Sometimes you have to change your IV bag. You'll give them a 500 cc's or 1,000, and then you have to change it. That's pretty easy. Just get your new bag, check it all out, do your check with your partner maybe, get it out of its bag, get it in your hand the correct way, rip out the area that covers I should say maybe the thing that covers the port, and then you're just going to basically turn the drip chamber off for a second. So here you see that first line there is stop the flow by closing the roller clamp that turns off the drip chamber. And then you're going to basically pull that out, put it into the new bag, and then flip it over, fill the drip chamber, make sure it's full, and then roll the clamp and it's going again. It's pretty easy stuff. To discontinue an IV, you just shut off the flow, undo the tape as much as you can, stabilize the catheter. Don't remove it from the tubing. Everything can stay together, so we're not going to have an air embolism or anything. And then pull everything out, apply pressure for 5 minutes. That's going to limit the amount of bruising they'll have. A saline lock, everybody uses saline locks now. I'm familiar with them. I like them. I use them. It's great. It's not a student thing. All right. It really isn't a student thing. There's not a lot in our curriculum for saline locks. And in our curriculum, basically, as we're getting ready for paramedics, we should be getting ready for worst case scenarios. And a lot of times everything, the patient ends up needing a drug, and it is poor technique to give drugs through saline locks. It's just that's the way our curriculum is the best way to do this, because anybody can have an untoward effect to any of the medications that we give, as simple as those medications can be, and that means aspirin and nitro and albuterol and Zofran and whatever one you want to come up with. They can have an untoward effect, and it's best to have an IV line. So a saline lock really for us as students is a good second line. We should always have an IV drip going just in case something happens. External jugular vein is one of the peripheral IVs. I just recognize the idea that the slideshow doesn't make a distinction between central IVs and peripheral IVs. And you have a quiz question coming up pretty quick that has that. So we as paramedics nowadays, it's in our scope of practice to start peripheral IVs. Peripheral IVs is your external jugular, and and all of the ones that are kind of on the periphery of your appendages. So that might be going from the foot, it could be on the top of the foot, the medial malleolus, which is the middle part of your ankle, just above there, there's a pretty good site. And usually you don't have much going up, but if you see something on a lower leg, you could probably start an IV there too. And then on the arm, anywhere on the hand, the wrist, the forearm, and up to the antecubital is ours. We could go a little bit north of the antecubital if you want to. And then we can start external jugular veins, which is in the neck, and you can see that fairly easy. I think it's a fairly easy target on a lot of patients. And those are all peripheral IVs. There's 3 central IV places that we can't hit. We cannot hit the femoral vein, which is where the femoral vein is. The internal jugular vein is off limits, and then the subclavian vein. So all of those are ones that doctors can hit with the same kind of needles that we have, basically, and they do that off from palpation and knowing the anatomy. But very often when you are cannulating those, you use a through the needle catheter. That's when you run a wire through the line. And we just don't do those. So we do not start central lines. And so here's another little picture of what an external jugular would look like. You usually can see it. I would say if you don't see it, don't go for this one. This isn't a blind stick at all. And if the person has their own pulse or you're doing CPR, what you can do is occlude this by just pushing on that sternocleidomastoid muscle there, kind of low by where the clavicle is, and it should fill up. And then you poke it. When you're doing this, here we have a little bit of a picture of somebody. You can see how big it is there. It moves a bit, so you might want to make that neck taut. It's a little bit kind of complicated the way that they describe this, and they do talk about this in the National Registry. It'll say place the patient supine in a head down position. By that they mean maybe almost a Trendelenburg. And then it says turn the head to the opposite side, which is kind of obvious, but it's when you're reading it in a question, it seems weird that they say that. You turn the head to the opposite side. That is the only way that really makes sense. Feel for the carotid, and make sure that you're not going into the carotid, and then cleanse the site and occlude it with your finger, and then you just poke it. Some people will tell you that you can use the catheter, comes in a little container. You can use that to bend the whole needle and everything a little bit. Sometimes you need to do that just to get your approach correct. Pediatric IV is pretty easy. We're going to use over the needle, and they're going to be some of those big numbers, 20, 22, 24, maybe even a 26. Butterfly catheters, we can use those also. I don't know if they're ideal, but that's kind of what butterfly catheters are for. And I think when the kids start walking, this medial malleolus is it's a very good site. So if you have a kid that's walking, that's 2-year-olds, 3-year-olds, 4-year-olds, they still have that chubbiness to their arms a bit. Throw a needle around their, just south of their knee, and sometimes you'll start to see that medial malleolus one, and it's easier to basically hold their leg and poke it also. And then when we're doing pediatric IVs, be careful of fluid overload. We don't want to do that. When we start an IV, sometimes our IV fluid will stop running on the way in, and we need to know how to troubleshoot that. First, we're going to just look at kinks and stoppers, basically. We could have done something to the IV administration set that stops it, or we could have kinked it. The height of the bag. So the higher the bag, the faster we'll go. Somehow with the physics here, if the height is below the heart, the blood will actually start to run into the IV tubing. And as it's just at the heart level, it might stop. As it's just above the heart level, it will go slow. And as it's straight above and maybe as high as it can go, that's the faster it will go. If you're using small catheters, the IV might not flow the way you want it to. And what we do when we're new is we leave our constricting band on very often. And that can let it work for a little while, but then on the way to the hospital, if we have them wrapped up and such, we might not recognize that that's still the case, that constricting band is on, and our IV will stop. It's just basically bad form all we have to do is undo the band. Very often, if we're in the vein, we're good to go. It could be that we're not in the vein anymore. And then here's some reactions and complications. The rest of this little slideshow is going to be local reactions is first, and then systemic reactions after that. So we can infiltrate the area. Basically, we skimmed across the IV, I'm sorry, across the vein, or we went through the vein. It might be that we put it in and it was just in a little bit, and then when the patient moved a little bit, they came out. Tape can get loose when they're really sweaty and such, and that can make it so that the catheter comes out also. So with infiltration, you'll start to see edema around the site. That's the big clue. Might start to hurt. Patient might say that feels cold in the area. If it's occluded, like we can block it by maybe the way they're moving their arm, the way we positioned it right into a valve. And it could be that we didn't ever actually get it into the vein that well at all. And now, because of minor movement or whatever, the IV is not running anymore. So a good thing to do at the beginning is maybe lower the bag, and it could be what's causing the occlusion also is just where the bag is relative to the patient. But when we can't get it to drip, and this is for the previous one also, is drop the bag lower than the patient. And if you start to see blood come back up the tubing, your IV is good. So just put it back up and just realize it's a slow moving IV. Vein irritation. So here now we're going to see some redness. The patient's probably, if they're awake and talking, is going to talk about some pain also. That vein irritation comes from too rapid infusion rate usually. So when we have that, what we would probably want to do is just start a whole new IV somewhere else, probably on the other side, and keep the vein, keep the equipment. Tell the doctor or nurse about it. They might want to look at it and see if there's something wrong with the fluid or with the equipment. Thrombophlebitis, that first one, that vein irritation, is phlebitis. So this one and the previous slide are kind of the same. And here we have inflammation of the vein. And it could be a lapse in our aseptic technique. So we might have caused there to be a problem, and now your body's recognizing that there's something there, and now it's having an inflammatory reaction to that. So pain and tenderness, redness, edema, all of those are signs of inflammation, also signs of infection. So this usually appears about several hours after the IV therapy, after we start it. So we don't usually get a good feedback on whether we're doing this to patients. If you work in a hospital system, usually you get your you understand that might be you that did that. When you start to see this with us or the nurse, we're going to stop it and start another IV somewhere else. Hematoma, we perforated the vein, so that might be in our technique. We hit it and went back and forth a little bit. It could be that they're on patient or on blood thinners, and it could have just been the way we removed the catheter and we just allowed a lot of bleeding when it was removed. And when we're doing this, we could hit a tendon, a nerve, a ligament. So be careful not to do this. Stay shallow. I don't like to fish for veins. Make sure you feel it. Hopefully see it. Feeling it is more important. You feel that sponginess of it. I say don't go for the deep ones, and then just catheterize those. You could hit an artery also. I saw one person do that. It causes pain, especially if you're trying to push fluid through the artery. It causes pain there, and a lot of inflammation. You're going to have an inflammatory effect from that for a while. When you see that you're doing that, with a person that I saw doing this actually hooked up the IV to it, and then the bright red blood went right up the tubing right away. And then we all basically said, stop that, pull it all out, and put a lot of pressure for 5 minutes so there's the least amount of hematoma as possible. So those were all the local complications. Here's some systemic ones. They could have an allergic reaction. Very often, this would be from something else that was in the IV. So again, this is one of those things where you want to make sure that all of your stuff is sterile and you're using aseptic technique. If you see the patient, isn't having any anaphylactic problems before, now you started an IV and you're saying, boom, this is probably the IV that caused this. You have to stop the IV. You can leave the catheter in place, stop the IV. You could attach a saline lock to that one, push a different type of saline in through there, keep that tied down. I would start a whole nother line on the other side. Treat anaphylaxis, and it says there aggressively, and then contact medical control. Retain the solution to see if there was some stuff that you couldn't see that was in there. Pyrogenic reaction is now, again, there's probably something in there that the person is recognizing as bad. Their immune system is, and so they're having an inflammatory reaction that's causing a fever. So a pyrogenic is going to be fever. And that's about 30 minutes after the infusion has started. So this is a big one that happens when you're doing transfers, and there's started something, maybe the colloid solutions and things of that sort, small hospital going to a big hospital, and the person spikes a fever. A pyrogenic reaction would be like maybe the first thing that you would think. Circulatory overload is just given too much fluids, or for the patient. So sometimes it's because the patient's kidneys are bad, and sometimes, and I would say most of the time, it's because at the beginning of our IVs we should run them wide open for a little bit to look for that swelling and such at the IV site, and then we get distracted by something else, and before you know it, we ran in 500 cc's, and now the person has some pulmonary edema. Just stop the IV, boop, and take care of what you see. Check in the lung sounds and tell people about it. It's not a big deal. Everybody does it pretty much some point in your career. And then an air embolism is possible. You need a lot of air to make a big difference. But if you notice that, we had a whole line of air there, and that we just administered to the patient, we should get ready for an air embolism. One of the old school ways of doing this is a left side. You put the patient on the left side with their head down, which is called the swimmer's position. Put them on 100% oxygen and go to the closest facility, and stand by for air embolism. So hopefully we just avoid that by being careful with our fluids, and when we're giving medications, we don't give them any air bubbles. Little air bubbles in the line are no problem. Once we start giving 5-10 cc's of air, that's a big problem. And a catheter shear. This is from moving your IV needle in and outside of your catheter while you're doing your poke. You want to avoid that at all costs. You could do this. I find it hard to do, but you could do it. And that catheter would be possibly in a vein, and that is going to just go up the vein. Veins get bigger as they go towards the central circulation, and then before you know it, you have a bad pulmonary emboli caused by a catheter shear. Could cause death of the patient. Position again is the left lateral recumbent, maybe head down too. The head down and such, that's supposed to be a good one for air. Wouldn't really matter with a catheter.